Hi, I'm Jeff Klein, editor of RadioGraphics, and I welcome you to the second of our podcasts for the November 2016 issue of the Journal, which features an interview with the authors of one of our highlighted papers. I am pleased to have Dr. Aparna Babu and Dr. Sudhakar Venkatesh join us for a discussion of their paper entitled Elastography in Chronic Liver Disease, Modalities, Techniques, Limitations, and Future Directions. Dr. Babu is currently an abdominal imaging fellow at the University of Pennsylvania, and at the time of this paper was written, she was a part of the Department of Radiology at Mercy Fitzgerald Hospital in Darby, Pennsylvania. Dr. Venkatesh joins us from the Department of Radiology at the Mayo Clinic in Rochester, Minnesota. Let me begin by asking Dr. Babu the first question. Dr. Babu, in the introduction to your paper, I was struck by the incidence of chronic liver disease both worldwide and in the United States. You make important points about the limitations of the pathologic assessment and serological tests for determining the extent of hepatic fibrosis in affected patients. You also briefly review the use of contrast-enhanced MR and CT to assess fibrosis, although it seems like these techniques are still relatively immature. Can you briefly describe to us the methods that are used to measure the elasticity of the liver, which you can see in Figure 2?
Sure, Dr. Klein. Thank you for your question. It's an excellent first question to help us introduce our readers to the concept of elastography. You're right, the incidence of incidence of liver disease is indeed striking. And I was amazed that as many as 30 million people suffer with chronic liver disease in the US alone. And one of the first steps in management of these patients is assessment of the degree of hepatic fibrosis, which is very important not only in treatment but also in prognostication of these patients. As we know, liver biopsy is a gold standard that all other modalities are measured by. And while it's a very good technique, it has its own limitations. And one of the most important limitations is that it's an invasive technique. And that comes with a small risk of morbidity and sometimes even mortality in some patients. And so there is ongoing focus on development of newer non-invasive techniques for assessment of hepatic fibrosis. Serological testing has been proven to be beneficial in a small subset of patients, especially for confirming or refuting diagnosis, but it's not very specific. Inflammation especially can mimic fibrosis in many patients, and also grading of the severity of fibrosis is not possible in many patients. That's where MR and ultrasound elastography comes into play. These modalities are useful not only in assessment of hepatic fibrosis for the presence or absence of fibrosis, but also they're very useful in grading the degree of fibrosis, and that's helpful in management of these patients. The principle behind elastography is really quite simple. It relies on measurement of mechanical response of a tissue to outside forces applied on that tissue. In many ways, it can be considered a sophisticated palpation technique that was used from several centuries ago. It can be divided into two main categories, as we see from our figure 2. And these techniques are either static or dynamic techniques. So in static techniques, a series of compressions are used as mechanical force, and deformation within a specific lesion is measured with respect to deformation of surrounding tissues. And it has been particularly useful in breast and thyroid lesions, but because the liver is a deep-seated tissue, it's less useful in assessment of hepatic fibrosis. Amongst the dynamic techniques, the common principle is production of shear waves within tissues. So either vibration or acoustic radiation force impulse is used to produce shear waves in the tissues, and the propagation of shear waves within the tissues is related to the elasticity of the tissues. So the less elastic or more fibrotic a tissue is, the faster it propagates these shear waves. And measurement of this velocity within the tissue can help grade the degree of fibrosis within these tissues. Shear wave imaging can be either dynamic or static. Examples of static shear wave imaging include the FibroScan, which is a very popular device, and that measures fibrosis by using vibration as its force to produce shear waves. And it's an outpatient technique that can be performed in many offices, simple, straightforward. There's also use of ARFI, which is acoustic radiation force impulse, for example, in point or supersonic shear wave techniques. So what it does is uses sound waves to produce shear waves, and measurement of these shear waves again helps grade the degree of fibrosis. The supersonic technique uses continuous acoustic radiation force impulses to produce a cone of shear waves, and it's a much more sophisticated technique. More of the liver tissue can be assessed, but it is still in nascent stages, so it's still in infancy, not widely available in the market. Finally, MR elastography uses continuation vibration to produce shear waves. A special motion encoded GRE sequence helps determine the degree of fibrosis in these patients. And going forwards, I think that will be the main modality used for assessment of elastography.
Great. Well, thank you so much for that. Let me ask you, what would be the main clinical indications for the performance of liver elastography, particularly in the setting of patients with hepatitis C?
So the main indication is grading of fibrosis. As we talked about before, that's useful in management and treatment of these patients. With respect to hepatitis C, with the new polymerase inhibitor therapy, which is excellent, as compared to interferons, which came with a lot of side effects, cure rates approach 100% with polymerase inhibitor therapy without the associated side effects. So the only downside to this is that it's very expensive. A single treatment cycle costs about $90,000. And so insurance companies are quite stringent about who to provide these treatment to. And they are particular that there has to be advanced fibrosis in order to approve this treatment. So measurement of fibrosis and grading of fibrosis is useful in these patients. Not only that, but in patients with hepatitis C, the 5-year survival rate has been linked to the degree of fibrosis initially present. And also it can help assess treatment response by using elastography. Also, there are several novel indications for elastography, particularly in patients with hemochromatosis. Serum transferrin levels along with elastography measurements can help assess the degree of fibrosis in these patients. And one of the things that I particularly like, research is ongoing to actually determine pre-fibrotic stages where inflammation is present, and that inflammation is enough to cause alteration in the liver tissue. And if we can somehow measure the alteration produced by inflammation and differentiate it from fibrosis, then we can perhaps pick up these patients earlier and help treat them earlier. So that is another exciting approach. So looking forward to what the future has in store for us.
Terrific. Thank you so much, Dr. Babu. Let me turn to Dr. Venkatesh. Dr. Venkatesh, focusing now on MR elastography, you indicate that MR elastography is currently regarded as the most accurate, non-invasive method for the detection and staging of liver fibrosis. In Table 5, you provide a list of patient-related factors that influence liver stiffness. Can you take us through these various conditions and how they impact liver stiffness as determined by ultrasound and MR elastography, focusing in particular on those conditions where elastography is particularly helpful and those where it might be of more limited value?
Oh, well, thank you, Dr. Klein, for having us and for that nice question. Yes, you're right pointing out that MR elastography indeed has the highest accuracy for detection and staging of fibrosis. And you might be wondering why MR elastography has high accuracy. This is basically because it samples a large volume of liver tissue. Now, almost when we do with the standard GRE MRE technique, we assess about 1/3 of the liver volume for the staging of fibrosis. And this large volume of sampling overcomes the sampling error, which is the common problem with other techniques, including the ultrasound elastography technique and including the liver biopsy, which also samples like 1/50,000th of a liver. So the MR has very accurate because it has samples a large volume of tissue. In addition to that, it has got high inter-rater agreement. It has got high repeatability and reproducibility. And also, it has got very high technical success compared to the other ultrasound techniques as well as invasive techniques. So all this makes ultrasound a very robust, the MR elastography a very robust technique, and it is very accurate. Let's go to the table 5, where we have highlighted some of the patient conditions which can cause changes in liver stiffness. Now, liver fibrosis is the first one, which is indeed the one which has the most effect on the liver stiffness. And this causes increased stiffness, which is detected by both ultrasound and MR elastography techniques. And it is the reason why these elastography techniques are so successful and have been applied clinically. But in addition to that, there are other conditions which can also increase the liver stiffness, like conditions which lead to congestion of the tissue. For example, heart failure, right heart failure, or venous outflow obstruction, including Budd-Chiari syndrome. All these can cause congestion of the liver tissue and can cause increased stiffness. The other condition which can cause increase in the stiffness is inflammation. Acute inflammation, particularly like acute hepatitis, acute severe hepatitis, leads to edema, interstitial pressure increase, and that also can cause increase in the liver stiffness. Now, chronic inflammation does cause an increase in the stiffness, and that to a very lesser magnitude compared to the acute inflammation, but it does add on to the amount of stiffness we measure when we measure for stiffness. So in this regard, I would like to highlight that steatohepatitis, which is going to be a very common chronic liver disorder soon in the US, because NAFLD is going to be the most common cause of chronic liver disease. And simple steatosis does not cause increase in stiffness, whereas steatohepatitis, that is inflammation along with the fatty change, will cause increase in stiffness. And this increase in stiffness can be helpful for differentiating NASH from simple steatosis, which majority of the people will have. So as everyone is aware, NASH is important to be, is particularly need to be detected earlier because that's the one which has got higher risk to progress to fibrosis, cirrhosis, and more, and so forth. And on the same line, acute alcoholic hepatitis, like somebody goes for an acute binge of alcohol, that can also cause severe inflammation of the liver. And that time, liver stiffness can be higher. So we need to take into these consideration that whether patient has this coexisting confounding factors before using any elastography techniques, whether it's MR or ultrasound, because these are going to increase the stiffness and you're going to give you falsely elevated stiffness and you might interpret as cirrhosis. So you got to be careful to rule out these conditions. And regarding the fasting status, now it's very interesting. Liver has dual blood supply from artery and portal vein, and the portal vein supply comes from the is fed by the mesenteric circulation. So when a person eats, the postprandial situation is typically between 30 minutes to 2 hours, especially a high carbohydrate meal, that increases the flow into the mesentery and increases the flow into the portal vein. And when this increased blood flow comes from the portal vein, the normal liver is a very soft, compliant organ, like a sponge. So when this increased flow comes in, it accommodates this without any increase in the stiffness. So in a normal patient or a normal volunteer, the stiffness does not increase. But a fibrotic liver is less compliant. It cannot distend much. So when this increased flow comes, it gets stretched. The capsule gets stretched, as a result of which the stiffness increases. So if you measure the stiffness in a patient postprandial who has fibrosis, the stiffness is going to be higher than what would be when he's in a fasting status. So it is very important that patients should always be scanned in a fasting status. And fortunately, clinically, we always scan patients in fasting status. So this should not be a problem because fasting status, at least minimum of 3 to 4 hours, should be easy to follow. The other condition which might affect the elastography techniques, particularly MR elastography, is the iron overload, like patients having hemochromatosis. Now, the standard MR elastography technique which we use is the GRE technique, which is very sensitive to the presence of iron in the liver, and this causes signal loss. Now, mind you, this does not prevent shear waves going through the liver, but the shear waves are not visualized because there's no signal coming from the liver, and we cannot assess the shear waves going through the liver. So if you have very severe iron overload, then MR elastography can fail just because there's no signal from the liver. So you might wonder, what will you do in those conditions? In those conditions, you might go for ultrasound elastography if need to be done. Or it so happens in our clinical setup, hemochromatosis patients become very good blood donors because they go for a lot of phlebotomies. And when they go for a lot of phlebotomies, the iron will come down. And once the iron is come down and you're worried about fibrosis, you can do an MR elastography. And lastly, we're going to the lower part of the thing is the, as I already mentioned, hepatic steatosis or fatty change per se does not affect the stiffness evaluated by MR elastography. There's been a lot of studies who have proven that. But there are some studies which have shown that ultrasound elastography may show an increased stiffness in these cases. So you have to be careful in those patients who have high BMI, a lot of fat, and you're suspecting that they may have a bit of steatohepatitis, they may have a higher increased stiffness. And MRE can be easily be performed even in high BMI patients, and even with those who have large amount of subcutaneous fat, where ultrasound elastography techniques may fail. But I would say this, as long as the patient fits into the MR scanner, you can do MR elastography. If you cannot, then you have to go for other techniques. But unfortunately, these patients are those in which ultrasound also fails. So these are the patients in which we have to go for other techniques like clinical tests, or sometimes we might even have to resort for biopsy. And so far in all the publications which we have seen over the last 10 years, age and sex do not affect liver stiffness. Although someone might wonder whether men may have more liver stiffness compared to women, and maybe it is related to alcohol intake, but we don't know. We cannot say anything about that. But in summary, I would say both ultrasound and MRE are useful for evaluation of liver fibrosis. And we have to pay particular attention to confounding factors such as passive congestion, heart failure, acute inflammation, acute alcohol intake. These can falsely elevate the liver stiffness. And always perform elastography in fasting status and follow up the same in fasting status.
Great, thank you so much for that. Let me ask you one other question follow-up. Your paper provides a fairly detailed description of how to perform magnetic resonance elastography, and in particular how to interpret the resultant stiffness patterns and correlate these with the anatomic imaging. Can you take us through some clinical examples of patients as illustrated in figure 15 in your paper?
Thank you again for the question. Yes, MRE does provide a cross-sectional view of the liver where we perform the elastography. MRE typically is performed with 4 slices, and these 4 slices go through the largest cross-section of the liver, and it gives you a snapshot of a cross-section of the liver, and at the same time the stiffness map will provide you the distribution of the stiffness. It's very interesting. Initially we didn't think that this distribution of stiffness is something to do with the heterogeneity of fibrosis and may not be very important, but as we improve or as we increased our experience, we started noticing that particular diseases or particular conditions do have a characteristic pattern of stiffness pattern. For example, if you look at figure 15, the first image, they were top row images. The one on the left will show, I'm bringing up the image on my hand over here. The top image, A and B, on the left shows the stiffness map, and on the right is the contrast enhanced CT. Now, if you look at the contrast enhanced CT, there is peripheral hypodensity where the arrowhead shows, and this is an area of passive congestion. This patient has constrictive pericarditis, and you can see the IVC is kind of congested, and this leads to passive congestion. And this passive congestion goes all the way to the sinusoid levels and stretches the capsule and predominantly affects the peripheral part of the liver. And when you do MRE in this condition, you can see that the stiffness map actually shows the red and yellow regions in the periphery of the liver, corresponding to the areas of passive congestion. So this information goes along with what we see on the imaging, which we didn't probably knew what was happening, but we have an evidence now that this is the area of passive congestion, and it leads to increased. I feel this kind of an appearance can also be seen in primary sclerosing cholangitis, in which peripheral ducts are involved, and then these ducts will lead to fibrosis and stiffness in the peripheral part of the liver, And you can see the peripheral rim of increased stiffness, whereas the central part may be going for just for hypertrophy, and you may not see increased stiffness. And if you look at the second image, which is a case of primary sclerosing cholangitis and shows a focal area of increased stiffness as shown in the arrow on figure C. And this is an area of biliary stricture along with biliary dilatation. And you can see that on the correlate on the T2 weighted image in figure D, in which it shows hyperintensity in that region and dilated ducts. Now, these features were initially identified before, and everybody knew these things are happening in primary sclerosing cholangitis. But we now have a correlate. Again, it corresponds exactly to the area of stiffness, area of signal intensity. And if we happen to do diffusion-weighted imaging in this patient, it will show a restricted diffusion in the same place. And if we do arterial phase imaging, it will show arterial phase hyperperfusion at the same place. So all these correlate exactly to the same area of stiffness. Now, you might be wondering, how is this useful? Because if you do an ERCP in this patient and do relieve the biliary stricture, that particular area of stiffness will go, and really showing that there is a response to whatever intervention has been done. And if you, in the future, right now, primary sclerosing cholangitis does not have a treatment. In the future, if there's a treatment available, we can show these changes occurring with the treatment, and this will be helpful. And these changes are very focal. They won't occur globally in early part of the disease. And you can see these kind of changes also in autoimmune hepatitis, in which you have rings of hyperplastic nodules surrounded by stiffness or fibrotic nodules. So all these changes can occur, and these changes can be very subtle and distributed in throughout the liver. And let's look at the third example, the one with figures E and F, showing a case of autoimmune hepatitis with confluent fibrosis. Now, if you look at the MR elastography stiffness map, the arrow points to an area of increased stiffness in one particular area. And this corresponds exactly to a hyperintensity on the T2 weighted images, which is a confluent fibrosis. Now, this is exactly the region where there is a lot of fibrosis, and MR elastography exactly corresponds to that. So these kind of information, let's say in a patient who comes in with an early autoimmune hepatitis or primary sclerosing cholangitis, if you do an elastography and you see some areas of stiffness and some areas of normal areas of stiffness. So if you want to do a biopsy for any clinical indication, such as for going for a trial or something, you can actually direct where to do the biopsy in order to get a positive result. So MR stiffness maps can be useful for that, to do a biopsy if at all is needed. But we are seeing more and more of these stiffness patterns. These patterns can also change with treatment. And we have to see furthermore a kind of an experience to see how this stiffness pattern change with any other particular disease. But in general, MR elastography gives you a snapshot of what is happening, a cross-sectional view in the liver, and which part of the liver is affected, and which part of the liver is more affected than the others. And this may be useful for evaluation of treatment or for a response assessment.
Well, that's terrific. Thank you so much for that. I just want to thank Dr. Venkatesh from the Mayo Clinic, Dr. Babu, currently at the University of Pennsylvania, and from Mercy Fitzgerald Hospital in Pennsylvania, for taking the time today to discuss their paper on liver elastography with me and with our readers.
Thank you.
Thank you.